Okay, I should be recording now.
Yeah, go ahead.
Okay, perfect. As I was saying, good evening, everyone. My name is Humzah Abdulkader. You guys may know me as I've done the MSI review and the CVP review already. So for this review, I'm thinking we'll probably be doing it the same way that we've done the other ones, where I'll give you guys like a minute to kind of read the question and come up with your own answers. Then I'll read it with you and I'll kind of go over the question, go over the answers. And for some of the more, what I think are more high yield or important topics, I put explainer or summary slides afterwards. So if you guys are ready, we'll just get started. The first question. And if you guys can type your answers in the chat if you'd like. Okay, let's go over the question. So, the parents of a 6-year-old girl noticed that she has become increasingly lethargic over the past 2 weeks. On examination by the physician, she has puffiness around the eyes, her temperature is 36.9, and blood pressure is 100/60. Laboratory findings show a serum creatine of 0.7 and urine nitrogen of 12. Your analysis shows a pH of 6.5, specific gravity of 1.011, and 4+ proteinuria, and no blood or glucose. The 24-hour urine protein level is 3.8 grams. The child's condition improves after glucocorticoid therapy. Which of the following findings by electron microscopy is most likely to characterize this disease process? Okay, so you guys are saying that it is E, right? So that is the correct answer. The question here is asking about minimal change disease, correct? So what gives away that this is minimal change disease? Well, actually, first, before I start with that, I want to go over like these kind of questions in general. What do you want to do? So the first thing you want to do in these types of questions is to figure out, is this nephrotic syndrome or is this nephritic syndrome, right? So if we go here, nephrotic syndrome, nephritic syndrome, they can be similar, but you got to know the differences between them. So first of all, the first thing in nephrotic syndrome that you have to know is proteinuria is more than 3.5 grams a day, right? So in our patient, they say that it is 3.8 grams a day. So immediately we already know that most likely it's nephrotic syndrome, right? Now, additionally, they'll have edema due to a decrease in albumin, which is part of the loss of protein in the urine, right? And they oftentimes won't mention any casts, but if they do, then they'll mention that there's fatty casts. Additionally, they're predisposed to infection because they have low gamma globulin, and they lose antithrombin 3, which basically leads them to be in a more coagulable state. Now, these last three are not as high yield, but I think they're just important things you should keep in mind. Like you won't often see them in questions. The things that you're going to see for sure are proteinuria and edema, which is what we see in this question, right? So in general, with minimal change disease, we'll go here, it's the most common cause of nephrotic syndrome in children. So if you see a child that has symptoms of nephrotic syndrome, your first thought should be, this is minimal change disease, right? Now, if you see something that tells you otherwise, then you can go through that. But the first thought should be, this is minimal change disease. So on light microscopy, you'll find normal glomeruli. Now, this is important because what happens sometimes, and I've seen it asked in the past, is what they do is they'll ask you, instead of which of the following findings by electron microscopy, they'll still put this E, effacement of podocytes, but they'll put another answer that says normal. And the question will say, which of the following findings by light microscopy? So you have to really read the question and see what it's asking, because if they ask about light microscopy and you put effacement of foot processes, that is the wrong answer and you'll get the question wrong. And so you really have to focus on what are they asking for? Are they asking for immunofluorescence? Are they asking for light microscopy? Are they asking for electron microscopy? So specifically with minimal change disease, I've seen this in the past where they do ask for light microscopy. So I'd say keep that in mind when you're going through the questions. Additionally, it has a very good response to glucocorticoids, and this can help you differentiate from other nephrotic syndromes as well, because I'll go over it a bit later, but focal segmental glomerular sclerosis can present very similarly to minimal change disease. But one of the main differentiating factors is that this one responds to steroids, and FSGS does not respond to steroids, or it doesn't respond as well. Now, coming back to this, we mentioned the things in nephrotic syndrome. Now, for nephritic syndrome, some of the things you need to be looking for is that they also do have proteinuria, but it's not as much, okay? So even if they mention proteinuria, it does not mean immediately nephrotic syndrome. You have to look at how much proteinuria. That's very important. Additionally, you want to look at, is there hematuria and is there RBC casts? If there's RBC cast, that means most likely, this means there's damage to the glomerular structures, because most likely it is nephritic syndrome. Additionally, oftentimes they'll present with hypertension or oliguria. Does anyone have any questions on this question? Okay, perfect. We'll move on to the next question then. Okay, let's go over the question. A 50-year-old woman has had fever and flank pain for the past 2 days. On physical examination, her temperature is 38.2, pulse is 81, respirations are 16, and blood pressure is 130/80. Your analysis shows no protein, glucose, or ketones. Leukocyte esterase test is positive. Microscopic examination of the urine shows numerous polymorphonuclear leukocytes and occasional WBC casts. Which of the following organisms is most likely to be found in the urine culture? Okay, so you guys are saying the answer is C. Now, this is a very, I think, very simple question. This is, it is definitely C. Now, if we look at the question, they have fever, flank pain. So these kind of systematic signs, these are systematic signs of pyelonephritis, right? And they also mentioned leukocyte esterase is positive, and there's WBC casts. Okay, so all of these point towards pyelonephritis, and the most common cause will be E. coli, right? Definitely none of the other ones are even. I don't think you even take. I don't think we've even taken any of the other ones. So I think this is a very easy question. So unless anyone has any questions about this, we can move on to the next one. Okay, let's go through this question. A 58-year-old, relatively healthy man sees his physician for routine health maintenance examination. Physical exam shows mild hypertension. Laboratory findings show a serum creatine of 2.2 and urine nitrogen of 25. Microalbuminuria is present with excretion of 250 milligrams a day of albumin. 2 years later, he returns for a follow-up visit. He is now hypertensive and has a serum creatine of 3.8 and urine nitrogen of 38 and a 24-hour urine protein of 2.8 grams. Renal biopsy is done. Light microscopic appearance of a PAS stained specimen is shown in the figure. Which of the following laboratory findings is most likely to be abnormal in this patient? Okay. You guys are saying it is diabetic nephropathy. That is correct. This is diabetic nephropathy. What are we seeing in this picture? What can anyone name what this is called? What are the findings here? Okay, yeah, because a lot of the time they won't even give you the picture. They'll just tell you they sometimes they'll call it nodular glomerulosclerosis. They'll call it nodular sclerosis or whatever. They'll say that's shown on light microscopy. So that is also referencing the Kimmel-Wilson nodules. So for this question, I took this picture from the lecture because what you guys should do is you guys should really memorize the pictures from your lectures, because on the exam, 90% of the time, they'll bring the same exact pictures. I say 90% because for us, I remember we had one OSPE question on Wilms tumor where they brought the picture from Google. We'd never seen the picture before, but the rest of, like, it gave one option, which is one from Google. The other four options were stuff from the slides. So if you knew what the other four were, then you know that, okay, the one picture I've never seen, that's the one that's going to be Wilms tumor, because I know all the other ones are not Wilms tumor. So I think if you can memorize all the pictures from the slides, it'll really help you, especially in OSPE, because like they just bring you the picture, like based on the picture alone, you got to figure out, okay, what is this? I think this question is relatively easy as well. So unless you have any questions, we can move on to the next one. Okay, let's go over the question. A 44-year-old man has developed a fever, non-productive cough, and decreased urine output over the past 3 days. On physical exam, his temperature is 37.7, blood pressure is 145/95. He has sinusitis. On auscultation, crackles are heard over all lung fields. A chest radiograph shows bilateral patchy infiltrates and nodules. The serum creatine is 4.1 and the urea is 43. The results of serologic testing are negative for ANA, but positive for C-ANCA. A renal biopsy shows glomerular crescents and granulomatous vasculitis. The result of IF staining with anti-IgG and anti-C3 antibodies is negative. What is the most likely diagnosis? You guys are saying that it is G, Wegener's granulomatosis. Now, why are you guys saying this? Because first of all, they mentioned kind of some, like, what's it called? They mentioned some symptoms of Wegener's, sinusitis, lung involvement as well. And kidney involvement versus renal. But also they mentioned here that it is C-ANCA, and C-ANCA automatically should point you towards Wegener's. But the thing that I want to focus on here is the second last line here, the result of the immunofluorescence staining. So when it comes to this crescentic glomerulonephritis, it's very important to know the differences, because under that there are several diseases, right? So if I go to this slide over here, there are several diseases that come under it, right? And so the way that you want to differentiate it is based on the immunofluorescence. So for linear immunofluorescence, and you want to make sure you go back to your lectures and memorize the pictures of how they look like, okay? For linear immunofluorescence, your immediate thought is Goodpasture syndrome. And that's because you get antibodies to the basement membrane, right? And so because it's antibodies to base membrane, it comes and it just goes to every single area, right? So it's just a linear, it shows like you'll see like a green line, right? Now the difference in granular is, for granular immunofluorescence, that means that there's some kind of immune complex deposition. And so when immune complexes deposit, they don't deposit in a linear fashion, right? They'll just deposit anywhere. And so because of that, on immunofluorescence, you'll see that it's just that starry sky appearance, lumpy, bumpy appearance. So that is pathognomonic for granular immunofluorescence, right? And so we see that in post-streptococcal and also in diffuse proliferative. And so post-streptococcal, this causes immune complex deposition. Diffuse proliferative is associated with lupus, that also causes immune complex deposition. So if you see granular, your first thought needs to be, okay, this is immune complex deposition. Now, what kind of, is this lupus? Is this post-strep? You got to look at the rest of the question for that, right? And so in our question, they said that there was nothing, right? They said it was negative. And so when it's negative, that means there's no staining, right? So I think the picture in the slides, it shows a little bit of green, but for the most part, there's nothing there. It won't show anything, right? And so what you want to look at if the immunofluorescence stain doesn't work, the next thing you look at is the P-ANCA and C-ANCA, right? If it's P-ANCA, then you want to then it's between Church-Strauss and MPO or MPA. Sorry, and so based on that, I think you guys know the differences between them, so you can kind of figure out, okay, do they have asthma, stuff like that? Then it's more towards Church-Strauss, and so based on that, you should be able to tell the difference between those two. And then if it's C-ANCA, your first thought is immediately Wegener's. We had an SAQ about good pasture syndrome. So I would definitely go back and look at just everything to do with good pasture. It's fairly easy. It's not that difficult. Type 4 antibodies, right? Antibodies type 4 collagen, sorry. They didn't ask very difficult questions. I remember, I think we only had 2 SAQs. One was on BPH, one was on good pasture. So, and I think good BPH was repeated as well. So I'd say definitely go through those. If you guys have any questions about this one, feel free to ask. If not, then we can move on to the next one. Okay, great. Okay, so I think this one's fairly simple as well. A 10-year-old boy comes to the physician because of a formal history of intermittent red urine. In the past 2 years, he has recurrent episodes of swelling on his face and feet. 5 years ago, he was diagnosed with mild bilateral sensorineural hearing loss. His uncle died of kidney disease in his 20s. His blood pressure is 145/85. Studies show that his hemoglobin is 12.5, urine nitrogen is 40, and creatine is 2.4. Urinalysis shows 5 to 7 RBCs per high-powered field. Which of the following is most likely underlying cause? You guys are saying it's A, type 4, defective type 4 collagen, and it is Alport syndrome. That is correct. What I want you guys to know about this as well is that sometimes they won't mention that the child himself has hearing loss. They'll mention that maybe someone in his family had hearing loss. They'll say like, oh, his uncle had hearing loss or something like that, right? And so because this is an X-linked disease, right? Because it goes through the family. So just because he doesn't have hearing loss, if someone in his family does, it could still be Alport syndrome. So keep that in mind. They don't necessarily have to say that he had it. See here, they said that his uncle died of kidney disease, right? So they can also reverse it and say that his uncle had some hearing loss. And so that's something you also have to keep in mind. If you see renal disease plus kidney disease, most likely it is Alport syndrome. They might also mention some ocular disturbance. They'll mention something about the lens. That's also something they can do. But yeah, family history, renal disease, hearing loss, and then possibly some kind of ocular disturbance. That's what you want to look for in Alport disease. Yeah, so a question like this, you guys should, even without reading the question, I want you guys to just look at the picture and know what the answer is, because this will also come in OSPE. And so if you can memorize what the crystals look like, then you don't even need the scenario. You can just look, be like, okay, what type of crystal is this? First, someone tell me, what type of crystal is this? Coffin lid crystal, yeah. So this coffin lid crystal means that it is E, right? Triple phosphate, magnesium, ammonium phosphate is the same thing. So I would definitely, again, go over this lecture and go over the casts and the stones. I'll go over the casts at the end, but definitely go over them. Go over what they look like and it's like. This is the rosette or whatever. I don't know what he calls it in the lecture, the star one. Make sure you know what they all look like, because they will come like this, and you'll have to know which one it is based on the picture. And if you do know which one is based on the picture, it just makes your life so much easier. Like if you know that, okay, if I see the envelope, that means calcium oxalate, then you don't even have to read the question. You don't have to waste time doing any of that. Just based on that, you can just get it right. But in case you do need to read the question, you can differentiate it easily based on the risk factors or the urine pH, stuff like that. I put in the notes of this slide different risk factors and stuff for each type of stone. So if you want to go look over that, you can. But in my opinion, based on like most of the time, they'll bring the picture with it. And so based on the picture, I think that you should be able to get most of the questions right. But in case they don't bring the picture, I think just go over. So I think that they'll bring this picture and they'll say, okay, what is this? Or they'll bring this and then you have to say this is calcium oxalate. Okay, so definitely go over that. I don't think they'll bring like a full scenario where they say, okay, the guy has polycythemia or gout or whatever, and I don't think they'll bring all that. But I think just in case they do go over, it's not that difficult. There's only I think 4 or 5 stones you have to know. So just go over them, go over the risk factors for them, go over what they look like, what the crystals look like. And yeah, I think based on that, you're in PH. I don't think that's that important, but based on that alone, I think that you should be able to answer most of the kidney stone questions. Because if they do, like they'll bring like, okay, for instance, for the triple phosphate, they'll say that he was infected with like some kind of urease positive organism. They'll say like maybe they'll bring like the imaging. They'll show like a staghorn calculi, right? And so if you know the association, then the staghorn calculi, it just becomes easy, right? They can also ask it the opposite way, where they'll bring you this and they'll say, okay, which organism caused this, right? Then you just put Proteus or whatever. And so that I feel like the kidney stone questions shouldn't be too difficult. Is that clear? Okay, great. Okay. I brought this one because this is pretty similar to the question we got as our SAQ. Except they brought this and they brought a picture of the light microscopy, and the light microscopy showed crescents. So the answer here is it's B, anti-GBM antibodies. Now, what you kind of want to look at is first of all, here it says he has hemoptysis. It shows he has pulmonary infiltrate. So they mentioned that he has pulmonary problems and he has renal problems, right? Now, someone said E. The problem with E is that it's more than just this, right? E also has nasal problems, it has lung problems, it has renal problems. We saw in the earlier question the difference between what a Wegener question will look like and what a Goodpasture question will look like, right? So if you just see hemoptysis or some kind of like lung problem plus a renal problem, then most likely it'll be Goodpasture. It won't be Wegener's. So I think definitely no Goodpasture in case it comes as a SEQ for you guys as well. And I think most likely it'll come with the picture, with the crescent picture, but I don't think you need it. I think also you should be able to based on the immunofluorescence as well, right? So for Wegener's, the immunofluorescence won't be there, right? Partially immune, but for Goodpasture it'll be linear. So I think that it's pretty simple. Do you have any questions on this? Okay, no questions. Yeah. So I think when it comes to Wegener's, I think you want to be looking for nasopharyngeal involvement, lung involvement, and renal involvement. Okay, I'll look for all 3 of them. Okay, nice. A 61-year-old woman sees a physician because she has experienced increased malaise for the past 5 years. On physical exam, there are no abnormalities other than blood pressure of 150/95. 1 week later, she dies suddenly. At autopsy, both kidneys have the external and bisected appearance as shown in the figure. So again, so ignore this part because I took out the picture that was there and replaced it with the one in your the one that was in your lecture, because I think you're more likely to get the picture from your own lecture than the one that's on these Q banks. So you guys are saying that the answer here is B, and that's correct. So the answer here is ruptured berry aneurysm. When it comes to the ADPKD, I think it's also simple. What you want to know is that it causes bilateral enlarged kidneys, right? And additionally, you want to know the mutations. He likes to ask about the mutations. I don't know why Abrar loves mutations, but he loves them. PKD, sometimes I think for us, he asked about the chromosome. So know the chromosome as well. I think he didn't ask about PKD2, he only asked about PKD1. But in case you want to know it as well, I put it here. Again, associated with berry aneurysms, mitral valve prolapse, hepatic cysts, and diverticulosis. So the most important one, in my opinion, is berry aneurysms, because that's the one that can lead to death, right? And then you also want to know what the difference is between autosomal dominant and autosomal recessive, right? Autosomal recessive is seen in children or in infants, and autosomal dominant is seen in adults, right? And so in infants, oftentimes what happens is that their kidneys will fail before they're even born, right? And so they'll have what's called Potter sequence. I don't know if you took that or not, but if you didn't, then I'll just give you just like a brief overview of what it is. So Potter sequence is based on the fact that your kidneys produce urine, right? And so that urine that it produces inside the amniotic sac is the fluid that the baby is rolling around in, right? And so if the kidneys are messed up, then it can't produce the urine, and you have what's called oligohydramnios, which is when there's not enough amniotic fluid, and so the baby's very compressed. And so you get these signs of compression, right? The face becomes compressed, the lungs become compressed, the limbs become compressed, everything in the baby becomes compressed. Oftentimes they just die, right? It's not suitable with life. And so it's important to know the difference between that autosomal recessive and autosomal dominant. Here, autosomal dominant, you'll find that they present much later in life. Right here, I believe our patient was 61, right? And so because if you see a patient that's older, you just automatically know it's autosomal dominant. If you see an infant, you know it's autosomal recessive. Okay, in that sense, it's pretty simple. Other than that, I think that's most of like the high yield parts of that. Do you guys have any questions? Okay, no questions, and I'll move on. Okay. Let's go through this. A 69-year-old man comes to the physician because of a 1-week history of blood in the urine and fatigue. He has also had a 5-kilo weight loss during the past month. Physical examination shows pallor, cachexia, a non-tender right flank mass is palpated. A CT scan of chest, abdomen, and pelvis shows a 5-centimeter right upper pole renal mass and several pulmonary lesions. A biopsy specimen of an affected area of the lung is obtained. Photomicrograph of the biopsy shown below. I removed the picture because I think, in my opinion, would have confused you. A molecular evaluation of the specimen is most likely to show which of the following genetic changes. So you guys are saying the answer is C. Now, what is the, okay, yes, it is renal cell carcinoma. Now, what gives away that this is renal cell carcinoma? What we're looking at is, first of all, they say here that he has, a 5-centimeter right upper pole renal mass, right? But honestly, what I'm looking at is hematuria plus right flank mass. And oftentimes they'll also say that he has some kind of like flank pain, right? But They also mentioned here that he has systemic features as well, right? He has weight loss in the past month. He has cachexia, pallor, right? So all this shows that, first of all, most likely it is cancer, right? And then they say that he has several pulmonary lesions, and that means that it has metastasized to the lung, and these are called cannonball lesions, right? I'm sure you guys know that. What you want to know for renal cell carcinoma is the triad, right? In addition to that, you want to know risk factors. I believe there's more than these, like in your lecture, but these are the ones that are important. And then it's associated with von Hippel-Lindau, right? I don't think you really need to know what that is, like what the entire disease is, but just know the association because he can ask about it. Additionally, know this picture. You can see the clear cell, right? You can see the clear cells everywhere. And then also, it can lead to varicocele if it affects the renal vein, right? And it spreads hematogenously. That's why it can go to the lungs. It also goes to the bone, right? Now, one more thing that I want to mention is that it has a lot of perineoplastic syndromes, right? And these include polycythemia, which is the one that gets asked about the most. They'll say that they have elevated hematocrit or something like that, right? But it also presents with hypercalcemia, Cushing's, hypertension, etc., right? So these perineoplastic syndromes are basically options that they can ask about. These are things that they like to hook onto and ask about these things because people tend to forget about that stuff, right? And so I think that know these, know the picture, and also for this lecture in general, the gross images, like for instance, I believe it's oncocytoma, it says, the central scar, stuff like that. Know the descriptions for them, because he brings those pictures, he brings those questions. They should be very easy questions to just get right, just knock them out of the park. And then if there's like histopathology like this, then know them as well. I'm not sure how your batch is doing it, but for our batch, we had our lab committee basically go through the PowerPoints, especially the pathology PowerPoints, and basically they collected every single picture and they made a file of every single picture. And then with the picture, they said, okay, what is this? What are we looking at? And then if you just review that PowerPoint like the day before your exam, then that's your OSPE right there. Because most of your OSPE, like 95% of your OSPE will be from that. And so it's just an easy way to go over, because you only have micro labs now, right? You don't have regular labs anymore. And so I feel like micro labs are not that difficult. You can just go through it very easily. But the part that is difficult is to remember what the pictures look like. So if you can go over all the pictures, then it'll make your life very easy. Does anyone have a question about renal cell carcinoma? Okay, great. Okay, let's go through this question. A 54-year-old woman comes to the physician for a follow-up examination after presenting with elevated blood pressure readings during the last 2 visits. After her last visit 2 months ago, she tried controlling her hypertension with weight loss before starting medical therapy, but she has since been unable to lose any weight. Her pulse is 76 beats per minute, or 76 per minute, and blood pressure is 154/90. On the right arm is 155. Okay. She agrees to start treatment with thiazide diuretic. In response to this treatment, which of the following is most likely to decrease? So you got to read the question very carefully. It's asking here, you guys are saying A. It's asking here, which of the following is most likely to decrease? Now, A says serum uric acid levels, right? But what we know is in thiazide diuretics, the mnemonic is what? Hypergluc, right? Which is what is it? You guys tell me. What does hypergluc stand for? Yeah, glycemia, lipidemia, uremia. What's the last one? calcemia. Exactly. So and when it says which is most likely to decrease, the answer here would be calcium excretion, right? Because if calcium excretion is decreasing, that means it is increasing in the body, right? And so because of that, the answer here would be B. So again, what do you say? Glycemia, lipidemia, uricemia, calcemia, right? So all of those will increase in the body, right? And so a decrease of excretion means less is going out in the urine, means more is in the body, right? Does that make sense? The rest of them, serum glucose level, we just said it increases. Lipid levels, we said it increases. So just read the questions carefully. This was a little bit of a tricky question, not really tricky, but it basically tests, are you reading the question, right? Because it's very easy to just, okay, thiazide diuretic, okay, serum uric acid levels. Yeah, but is it increasing or decreasing? So here's asking for which decreases. So keep that in mind. I think we can move on to the next question. Okay, let's go over the question. A 69-year-old white man comes to the physician because of a 15-day history of fatigue and lower leg swelling. Over the past 8 months, he has had a 3.8 kilogram weight loss. He smoked 1 pack of cigarettes daily for the past 48 years. Vital signs are within normal limits. He appears thin. Examination shows 2+ pretibial edema bilaterally. An X-ray of the chest shows a right upper lobe density. Laboratory studies are shown below. Light microscopy examination of the kidney shows thickening of glomerular capillary loops and the basal membrane. Which of the following is the most likely diagnosis? So let's go through the answer choices here. Okay. Now, this, we know what that is, right? That's Wegener's. Wegener's, it doesn't mention anything to do with sinusitis or hematuria, anything like that. So it cannot be A, right? In fact, it mentions nothing, no urine, no blood in the urine, but he has protein 4+. So it's most likely a nephropathy, right? Membranoproliferative glomerulonephritis. They mentioned here the light microscopic kidney biopsy, right? What would we see if it was membranoproliferative? We would see thickening of the membrane, and we would see proliferation. It's in the name, right? Membranoproliferative. Membrane gets thickened plus proliferation, right? Which is not, they don't mention anything about proliferation here, which means that it cannot be B, right? Focal segmental, they would mention it's a focused area, it's a segmented area of thickening, right? And so they don't mention that here. So it most likely isn't focal segmental. Additionally, rapidly progressive, they would have mentioned crescents, they would have mentioned hematuria, they would have mentioned RBC CAS, something like that. They don't mention anything like that, which leaves us with E, membranous nephropathy. Now, another thing that you can look at in the question, which would have led you towards membranous nephropathy, is this, an X-ray of the chest, right? The membranous nephropathy is associated with solid tumors, right? And so that's one of the associations that you want to look for, right? I believe it is solid tumors. What was it? Solid tumors, hepatitis B, hepatitis C, SLE, and syphilis, right? So those are the associations you want to look for with membranous nephropathy, right? And so based on this association and the light microscopic findings, none of the other answer choices would have really made sense, right? The only answer choice that makes sense would be E. I think it's important for, especially like because the nephropathies can get kind of confusing, right? Like nephropathy and nephritis, like they can kind of get similar, get kind of mixed up, right? And so if you can kind of organize it in your mind as to what are the light microscopic findings, what are the electronic microscopic findings, what are the immunofluorescence of each thing, and then what are like the associations, if they have any specific associations, then I think that'll really help you answer these questions, right? Because if you know from before that, okay, solid tumors associated with membranous nephropathy, as soon as you see this, then the first thing you think of is membranous, right? But even if you don't know that, based on the description here, none of the other answer choices would have made sense. They have to be mentioning something about proliferation here, or like a segment, right? They would mention it in a specific segment here, or they'd mention crescents. So each thing has kind of its own buzzwords. So that's kind of what you want to look out for. Okay. Additionally, for this, they might mention, like the spike and dome appearance, right? So if they mention spike and dome, that also goes towards membranous nephropathy. So these are all things that they can put in the question that should lead you towards the right answer. I hope that was clear. Should I move on? Okay. Okay, yeah. So here, this is another buzzword that you need to be looking out for, right? Cola-colored urine, right? That tells you immediately what is the answer. A, post-streptococcal glomerulonephritis. But again, this is the picture here. So this is the, starry sky appearance. This is the granular, right? So I think even just based on the picture alone, that should tell you, okay, it's more of like an immune complex thing, right? And so that'll kind of lead you towards specific differentials. And then if you look at cola-colored urine, then that's it. 11-year-old comes to the 2-day history passing cola-colored urine. She had a rash on her face, so she had previous infection, right? So this is, I think, a pretty easy question that most likely will come, and you should get it right. There's no reason why you should be getting questions like this wrong. So I'll move on to the next question. It was a little bit more difficult. Okay, let's go to the question. A 47-year-old man is treated for bacterial sinusitis with ampicillin. A week later, he comes to the emergency department with fever and skin rash. He also reports low urine output, temperature is 37.5, blood pressure is 123/71, and pulse is 88. Physical exam shows a diffuse macular-papular rash. Serum creatine is 2.4, and urine sediment microscopy reveals 3 to 4 RBCs per high-powered field, and 5 to 10 WBCs, and 3 to 5 eosinophils per high-powered field. The pathologic process affecting this patient's kidney most likely involves which of the following structures? So you guys are saying that it is C. That is correct. What is the disease? Correct. Acute interstitial nephritis. Now, what they mentioned here that can lead you towards this answer, right, is first of all, he was treated with a drug, and then after having this drug, he had some kind of reaction to this drug, right? And then with that reaction, he reported low urine output. And so in acute interstitial nephritis, they get for whatever reason, in this case, drug induced, they get infection, inflammation of the interstitium of their kidneys, right? And so another thing you want to look out for here is diffuse macular-papular rash and eosinophils. If they mention eosinophils, then it is most likely acute interstitial nephritis, because there are not many other things in this renal block that you're taking that will show eosinophils in high-powered field. So if you see eosinophils, I think most of the time this will be the answer: acute interstitial nephritis. I like this table from UWorld. It just kind of goes over, these are some of the different causes, some of the different drugs that causes it, autoimmune diseases. And then the clinical features, we said rash, fever, it can be asymptomatic, but here in our case, there was a new drug exposure to which he had some kind of reaction to. And then Here, urinary eosinophils, that's a big, red flag. It shows you that it's acute interstitial nephritis. And then if they mention renal biopsy, then this is what they'll mention: inflammatory interstitial infiltrate. I think that this concept is not too difficult, but you just have to kind of realize what they were asking here. They were showing that he started a new drug, and then right after that drug, he had some kind of reaction to this drug, and that resulted in acute interstitial nephritis. And then the eosinophils here should help you kind of come to that conclusion. We'll move on to the next question. So this question is it's a pretty like long, winded question that I don't think you really have to know how to come to the diagnosis here, but I want you to know, once I give you the diagnosis, what is the cast that is associated with this diagnosis, okay? So the diagnosis here, so this patient, he's in the military, right? He's exercising a lot, and he has what's known as rhabdomyolysis, right? And rhabdomyolysis in this case leads to acute tubular necrosis or acute kidney injury, right? And so with that information, what is the cast? Correct. The answer is C. Now, which one of these is the answer? So which one of these is the granular cast? Bottom left, correct. So there he put two pictures. Both of these are granular according to his slides, according to Orban's slides. So these are all the different casts that are in your lecture. Know all of them and know what they all entail, right? So this is, what cast is this top left? Hyaline. Okay, and what does hyaline mean? What does it entail? What is the process, physiology? What is the disease behind it? So it's exercise, but in reality, it's mostly like a normal thing, right? Now, what is the one over here in the middle, top middle? An RBC cast, right? Which would mean most likely, yeah, glomerulonephritis, most likely, right? Now what is the one top right? The one top right is actually a WBC cast. Okay, so WBC cast means what? Pyelonephritis, most likely, yeah. And then we already said that this one was the granular cast. Well, granular cast we said was associated with acute tubular necrosis. What is this one here? Bottom middle. Waxy cast. And what is it associated with? End-stage renal disease. Okay, and then what the last one over here? Perfect. Epithelial. Okay. I'm not sure if you have to know what it's associated. Do you guys know what it's associated with? Okay, yeah, awesome. Now this is one of the last questions. I went through our the 12th batch exam file. First of all, I'm sorry, I don't know how it got that way. Basically, we got like 3 questions on this metabolic acidosis, whatever, and they told us that you don't need to know how to calculate anion gap, you don't need to know Winter's formula, you don't need to know any of this stuff. That's what they told us. but they brought questions on it anyways. Now we appealed it, and I don't know if they removed it or not. They didn't tell us, but this question already gives you the anion gap, and I have another question that doesn't give you the anion gap, so we can go through both of them if you want, or we can just go through this one. So you guys are saying that this is B, so let's go through it. 54-year-old woman presents with poorly controlled type 2 diabetes. She's nauseous and weak. Serum electrolyte test revealed her glucose 470, pH of 7.29, PCO2 26, HCO3 of 14, and she is positive for beta hydroxybutyrate. Her anion gap is 24. What is the cause for this patient's presentation? So I'm sure you guys know how to go through these questions, but first thing you want to do is you want to look at the pH, acidic or alkalotic or normal. In this case, it's acidic, right? Now we want to look at, is it metabolic or is it respiratory? So for respiratory, you look at the PCO2. Now, if the PCO2 is low, that's not acidic. That would be alkalotic, right? So that means that it's not a respiratory problem. So then we look at the HCO3. And in this case, HCO3 is low. So if the bicarb is low, that means, and the bicarb is low and the pH is low, that means it is a metabolic acidosis. Now, they ask if it's normal anion gap or large anion gap. Here, they gave the anion gap as 24, right? Which is obviously large. Now, when I was looking at this question, it said that the normal is between 12 and 20. For whatever reason, I removed that part from the question. But from what I know, it's between 8 to 12. I would double check that with the doctor or the lecturer or whatever. But I'm pretty sure that the normal anion gap is 8 to 12. And if it's above 12, then it's considered high. But again, I suggest you guys double check that. Regardless, in this case, 24 is high no matter what. Okay, 10 to 12, perfect. So the only possible answer here is large anion gap metabolic acidosis. Now, I have another. Let me see. I hid the slide here. I'll unhide it. So for this, right, this question is going to ask you what the underlying cause is. It's a little bit difficult, and you probably won't get a question on this level, but I think it's good to practice how to calculate the anion gap and compensation and stuff, just in case you need to do it. So I'll just go through this question with you really quickly. 55-year-old, poorly controlled type 2 diabetes, CKD, and hypertension, presents to the ED with worsening nausea, abdominal pain, and confusion. Serum labs are obtained. ABG shows pH of 7.27, PCO2 of 25. Which of the following most underlying cause? Okay, so first let's go through the question. They say here that she has a pH of 7.27. So immediately we know that this is acidic, right? So she has acidosis. Now, is it respiratory or is it metabolic? Most of the time, I'll give you a hint. Most of the time in these types of questions, they will ask about metabolic acidosis because that's the one where they can really ask a lot of questions for, right? They can ask about the causes, they can ask about anion gap, non-anion gap. So most of the time it'll be metabolic acidosis, but just in case it's not, I suggest you still go through and check the PCO2, check the HCO3, right? So in this case, again, PCO2, if we go back to the other question, it gave the normal values, 35 to 45. So in this case, it's low, so it's not the cause of acidosis, right? So then we look at the HCO3, it's also low, right? That means that this is metabolic acidosis, as we said, right? Now, if you want to calculate the anion gap here, what do we need? What we need, right? Let's go. I have the formula over here. We have sodium is equal to chloride plus, is minus chloride plus HCO3. So you can do it this way. You can do it Na is equal to Cl minus, however you want to do it. But basically, what you want to do is you want to take this number. Why is it yellow? You want to take Na, right? And you want to subtract Cl and HCO3 from it, right? So in this case, as you said, 138 minus 110 minus 10, right, is equal to 18. So if it's 18, right, and we said that the normal is 8 to 12, right, that means that this would be high anion gap, correct? Now, The only high anion gap in the options here is D. That's why you guys are all saying D. So the answer is D. You guys are right. But now, do you guys want to do the Winter's formula, or did he say that's not important for you guys? Okay, so this is the Winter's formula right here, right? 1.5 times bicarb plus 8 plus or minus 2. Okay, so if someone has a calculator, we can do this. Do 1.5 times the bicarb, which is 10. Okay, well, I mean, okay, which means that it is what, 15, right? Then we do 15 plus 8, right? That equals 23. Sorry, my handwriting's so bad. So then 23 plus or minus 2, right? Now, 23 plus or minus 2 is 25 or 21 to 25. So what we want to do is we want to see, is the PCO2 within that range? Is it within that 21 to 25 range that we just got, right? And if it is, that means that it is being compensated, okay? If it is not, that means that it is not being compensated correctly, okay? So 25 is within 21 to 25. It is one of those numbers, which means that in this case, it is being compensated, okay? So again, it's a fairly simple concept, but it's just a formula. Nobody likes remembering formulas. Nobody likes memorizing these things, but it's just 1.5 times the bicarb, whatever the bicarb is, right? Then that plus 8 plus or minus 2, because it's going to give you a range of numbers. I don't think you really need to worry about that. I really doubt that you will get questions that advanced or that complicated. But I think most likely they'll give you something that is compensated, but just to make sure, I think go through it. And if they give you the HCO3, they give you PCO, they'll give you all this stuff. Just go through it and make sure it's compensated. Most of the time it will be. I in the past, even for our exam, they're all compensated. They're all, I believe we had 3 questions. Two were high anion gap, one was not, although I might be misremembering. I think it's more important that you know the anion gap and how to calculate that, because even though they might tell you that they're not going to bring it, they might bring it anyways. So definitely know that, and definitely know how to tell if it's metabolic acidosis, metabolic alkalosis, respiratory acidosis, because that will definitely come. Even if anion gap doesn't come, that will definitely come. So this type of question will definitely come. So definitely know how to solve something like this. If you have any questions, please let me know. That is all the questions that I have. Feel free to ask me anything if you'd like. These are the formulas once again. No problem. I hope this was beneficial. I think this time the questions were a little bit easier. Last time they were a little bit more difficult. So I kind of got to find that, sweet spot where they're not too difficult, not too easy. But I like to keep it more towards like the high yield stuff, the stuff that I think that not only will come on your exam, but stuff that you should know anyways. Right? So stuff like the berry aneurysm stuff, even if that doesn't come on your exam, I think it's something that's very important. And even when you go into like your clinical years and stuff, the doctors will ask you about this type of stuff. So I think you should definitely know that. And for your exam, remember, memorize the pictures, know the difference between nephritic. For the clinical lectures, they are difficult. There's not as many questions from them. So I'd put more of your focus on pathology, but definitely don't skip out on the clinical lectures. Pharma, I think, is relatively easy. Micro, I think, is relatively easy. And I think that's it. For the urology, I think you guys are doing it tomorrow. In my opinion, it's also easy. It's not that difficult. You just got to know like the different testicular tumors. And there are a lot of them. But if you can memorize them now, it'll also help you when you do endorepro, because you don't take testicular tumors again, but you take ovarian tumors, and they're actually very similar. So if you know one of them, then the other one, you'll know it as well. So I'd say work hard on trying to know that now, because if you can get testicular tumors down, then when you get to endoreproductive, you don't need to spend a lot of time going over ovarian tumors, because there are a lot, but they are very similar to testicular tumors. So yeah, if you guys don't have any questions, then I will stop sharing my screen, and I guess I'm done from my end. So if there's anything else, let me know. Otherwise, I think we can end the meeting.